their comorbidity and complications of chronic liver disease increased over time. So the prevalence or the burden of comorbidities increased over time. It was found in the United States, and also it is found in Saudi Arabia. So it is very challenging to achieve the WHO goal, which is set a very high bar for us. WHO aims to reduce 90% of new infection globally, and to reduce the deaths by 65% by 2030. There are tangible strategies to achieve their goals. First, of course, by vaccinations, we can prevent transmission, and it is very important to achieve blood safety. But I think the more important is to identify the patients. We need to find 90% of patients infected with HBV, and to treat 80% of those eligible for treatments. So it's very difficult for every country, including the Kingdom of Saudi Arabia. So if you guys want to achieve their goals by 2030, then you have to avert more than 4,000 cases with hepatic compensations, and avert 9,400 cases of HCC cases, and save 9,500 lives. That is a very challenging goal. To achieve that, a group of experts in your countries have figured out tangible ways to do that. According to these experts, the first priority, the top priority, is to implement screening campaigns. Of course, we need to find the patient first in order to reduce the burden of the disease. Then we have to increase the primary care physicians' education's awareness of this disease, and enhance the link between primary care physicians and specialists. And then ideally, there should be a national registry of patients. So fortunately, these highly important strategies are also highly feasible. So I'm looking forward to your implementations of these strategies. Now let's move on the treatment for chronic hepatitis B. I think the goal is to improve survival and quality of life of the patients. There's no doubt about that. And we can achieve this goal by preventing disease progression, including reduction in HCC development. So not all nuclear analog treatments are equals. The older generation of drugs are no longer recommended. So according to the guidelines, the preferred regimens are either entecavir or tenofovir-based regimens. So tenofovir alafenamide is a new compound in its class. It is very unique in its stability in plasma. So people can use a small dose of tenofovir alafenamide or TAF as compared with the conventional TDF. And we share some data from the registration trial. It has been 5 years now. So there were 2 registration trials for TAF, and now we have data after 5 years. Initially, there was a randomized trial between TAF and TDF, and later on, it was an open label phase. So at 5 years, as you can see, that virological remission is not a problem for TAF. More than 95% of the patients can achieve viral suppressions, and ALT normalizations went up with time. With regard to serological and fibrosis outcome, in E antigen positive patients, the percentage of E antigen loss also went up with time, and the E antigen seroconversion ratio also went up with time. And after 5 years of treatment, the fibrosis improved in the vast majority of patients, which it was measured by fibro test. It's a non-invasive test. And how about the special population, especially those with renal or bone concerns? So according to the 5-year data, those who were initially randomized to take TDF have improvement in renal function as estimated by EGFR over time. And also the renal tubular function, which was measured by the beta-2 microglobulin over creatinine ratio in the urine. Also, as you can see, those initially randomized to TDF have improvement in this outcome over time. So TAF show a renal protection in this 5-year data. How about bone mineral density? And you can see that those who were initially assigned to TDF also have improvement in bone mineral density, either in the hip measurement or spine measurement. That suggests the superiority of TAF in the protection of bone mineral density. And treating patients with chronic hepatitis B is, of course, we want to reduce the risk of HCC. And there is also evidence suggesting that TAF can achieve this goal. This is the actual occurrence of HCC during the 5-year trial. It is significantly lower than the expected, anticipated rates of HCC. And there is some data from this study from South Korea suggesting that using tenofovir-based treatments, there might be a lower risk of HCC after 2 years of treatment as compared with entecavir. Although this issue is currently contentious, but there's some data suggesting that TDF as compared with entecavir is more effective to reduce HCC risk. Now, let's move on to special populations. We focus on pregnant women. According to the guidelines, all pregnant women should be screened for surface antigens. And for those with high viral load, which was defined more than 200,000 IU per ml, then they should receive preferably TDF at their 3rd trimester. And the treatments are continued to 1 month or 3 months after the baby was delivered. There is no contraindication to breastfeeding, and actually the obstetric concerns is similar to the usual patients. So we can see some data from China to support the use of TAF in pregnant women. So this is a single-arm retrospective cohort studies. There were 71 patients with e antigen positive and viral load higher than 200,000 IU per ml, and then received TAF from the 2nd or 3rd trimesters. And as you can see, the viral load decreased significantly in the mothers, which was, of course, and I think what's more important is the outcome in the babies. There was no transmission in all these 70 babies. So TDF at the 3rd trimester prevent transmissions, and the safety issues with regard to the growth parameter in the babies, the weight, the height, the head circumference were all compatible with the normal infants. Another study from China, this one is a multi-center study. It is a comparative study. It compares TAF versus TDF in pregnant mothers. And again, the viral load was greater than 200,000 IU per ml. And these the two groups were comparable at baseline. And as you can see, there was no transmission of the virus to the babies. And so I think in the Kingdom of Saudi Arabia, your guidelines even more advanced than what we see in the United States, because you suggest all pregnant women with viral load greater than 100,000 IU per ml to start treatments in the late 2nd or 3rd trimesters. And TAF is the preferred medication, and TAF could be used as an alternative. So the final question is that, should we just put on patient on treatments, or can we do better with current regimens? So this is a randomized controlled trial to test whether switching to TAF or continuing TDF will produce similar outcomes in patients with viral suppression using TDF. There were almost 500 patients in this randomized trial, and the two groups were comparable at baselines. And we have the 2 years data now. As you can see that the biological outcomes were excellent. The vast majority of patients could achieve viral suppressions, and either continuing TAF or switching TDF from TAF, over time, ALT normalizations increases. With regard to the safety profile, there's no signals, no dangerous nor unexpected safety events reported. And in patients already on treatment, I think there's one concept very important for all of us who treat patients with chronic hepatitis B, that we cannot just give patient medication without taking a look at the virus. So here is the term low-level viremia, which indicates that although the viremia below 2,000 IU per ml, the virus is still detectable in the serums. And we know that all guidelines suggest that the goal of virological response in patients who are treated with NUC should have an undetectable HBV DNA in their serums. So a detectable viral DNA is not an ideal goal. And there is evidence to suggest that why this is important. This is a study from South Korea. As you can see that as compared with those with complete virological response, those with incomplete biological response or low-level viremia had a significantly higher risk of HCC and significantly higher risk of liver-related deaths. The hazard ratio could be as high as 6-fold. So patient with low level of viremia is not ideal for disease controls. And this can be seen again in using the outcome of fibrosis progressions. Patient with detectable HBV DNA on treatments had a significantly higher risk of fibrosis progression as compared with those with HBV DNA undetectable. And what can we do about this patient with low-level viremia? So there are some data from China to suggest that switching treatment might be a strategy. This is a real-world study from China with 211 patients initially treated with entecavir, but still had a low-level viremias. So patient could switch to TAF or continue with entecavir. And we go on to see the outcomes. So the beauty of this study is that they use the propensity score matching to make these two treatment groups comparable at baselines. As you can see, the two treatment groups were comparable at baseline. And there is a higher percentage of cirrhosis in this study cohort, with 30% of them with cirrhosis. And after 12 weeks, the portion with complete viral remission was significantly higher in the TAF group as compared with the continuing entecavir group. And these differences went even more significantly at 24 weeks. There were more than 60% of patients in the switching TAF to TAF group achieved complete viral remissions. Compatible with the virological response, the outcome with ALT normalizations also indicates that switching to TAF was superior to continuing entecavir. Another study from China with nearly 500 patients. Again, this is a real-world retrospective cohort studies, and there were around 500 patients treated with entecavir, but still had a low-level viremia. So 104 patients of them switched to TAF, and the remaining 395 patients continue entecavir. And well, the baseline is that patients who chose to switch to TAF were significantly older. Other parameters were similar. And similar to the former study, those who switch to TAF achieve a higher rate of complete virological response, 40% versus 8% at 12 weeks, and the differences increase to nearly 80% versus 9% at 24 weeks. And along with virological response, the ALT normalizations again reveal consistent results. And there was no differences in lipid profile in this study. So in the real world, we participate in these international studies that organized by researchers at Stanford, that there were more than 200 patients joining in the switch studies. Patients could initially use entecavir or TDF or entecavir, but they switched to TAF. As you can find that either the virological suppression rates or EGFR, the renal function rates, showed excellent results. So the author conclude that switching to TAF is a feasible strategy in patients already on nuke therapies. So ladies and gentlemen, I would like to quickly conclude my talk by summarizing that patients with chronic hepatitis B are aging with increasing comorbidity and complications, including cirrhosis and HCC. In the 5-year follow-up of the 2 registration trials of TAF, this new compound continues to show that it is very efficacious in virological, biochemical, serological, and fibrosis measurements, and with superiority in renal and the bone parameters. In patients with renal and liver impairment, switching from TDF or entecavir to TAF showed that the virus suppression was well maintained and the ALT normalization was numerically improved. And again, the renal and the bone safety parameters were stable with TAF. And I think an important message from my talk is that we can't just put patients on therapy and ignore the importance of viremia, because low-level viremia, which was defined as detectable HBV DNA below 2,000 IU per mil, is still associated with disease progression, including fibrosis progression and risk of HCC. And in patients with low-level viremia, we had data from China, from real world, to show that switching to TAF might be associated with a better biological outcomes. With that, I thank you for your attention.
Thank you, Prof, for the excellent talk. Do you hear us, Prof?
Yes, very clear.
So we have a couple of questions before we conclude. The first question is, from practical point of view, how do we approach those patients who continue to have low-level viremia despite of TAF as a monotherapy?
Okay, so yeah, that's a very critical question, and I think this is an important one. If the patients still have low-level viremia despite using a monotherapy, there's data suggesting that combination therapy, using nucleoside analog and nucleotide analog might help the patient to achieve that goal. And the other concern is whether the duration of treatment is sufficient or not. Because as we can see from the clinical trials and also from real-world data, that the response rates of treatment increase over time. So perhaps if the patient is just started the treatment, we can monitor the patients for more times. And the third point, which I think is even more practical, is to confirm the adherence to medications. So from time to time, we have patients who just, hepatitis is not going to hurt him or hurt her, so he forgets to take the medications. So we need to confirm the drug adherence.
Thank you. The second question is looking to the different guidelines with regard to the cut limit, the suggested cut limit to initiate antiviral therapy during a pregnancy. The Western guidelines suggesting 200,000 international unit, and while Saudi guidelines suggesting 100,000 international unit. So how can we look to such evidence and apply it in clinical practice?
Thank you. I think that 200,000 units, the evidence for that comes from randomized controlled trial. There was a randomized controlled trial published in New England Journal of Medicine from China. The criteria in that study was 200,000 IU per minute. But I would not say that only pregnant women with a very low, very high would benefit from treatment. I think it's kind of a trade-off. We certainly know that the level of viremia is directly associated with the risk of transmission. So in Taiwan, unfortunately, the government set the level at 1 million. Personally, I think that's too high. But I think it's debatable. Yeah.
Sorry, again, what is the cut limit in your country?
1 million, too high, in my opinion.
In order to cover the medication by the governmental hospitals, right?
Yes.
Okay.
The national reimbursement policy said that, but usually the government is reluctant to pay. So, not in my country.
Okay, with this question, we'll conclude our talk. Thank you again, Prof, for the nice presentation and excellent discussion. Thank you.
Thank you. Thank you.
الو.
السلام عليكم. نحن صراحة كنا مبرمجين البريك يكون من 12:30 إلى 1:30، لكن إن شاء الله حنبدأ البريك الآن من الساعة 12 إلى الساعة 1 بإذن الله. نعاود نبدأ السيشن الأخير إن شاء الله تعالى. حياكم الله ومرحبا بكم، تفضلوا.
في هذا الوقت أطلقت المملكة العربية السعودية برنامج طموح لإزالة فيروس الكبد سي، وذلك عن طريق 3 محاور رئيسية.
وحتكون أرقامنا قريبة جدا من الإزالة، وسنصل بإذن الله بتكاتف الجميع وجهود الجميع إلى الإزالة بإذن الله في عام 2030 كما كان مخطط له.
وضعت رؤية المملكة 2030 هدفاً طموحاً يسعى لرفع متوسط العمر السعوديين بإذن الله تعالى إلى 80 عاماً.
بسم الله الرحمن الرحيم. نرحب بالضيوف الكرام في الفقرة الأخيرة أو الجزء الأخير من يومنا. الجزء الأخير بإذن الله بيكون فيه تقديم واحد عن موضوع الهيباتيتس بي، واسمحوا لي أرحب بالمتحدثة القادمة دكتورة غادي سبحي. She's a consultant in preventive medicine, Director of Hepatitis Control Department in Ministry of Health. وما شاء الله she is one of the pioneers وstars في الهيباتيتس prevention على مستوى المملكة. تفضلي دكتورة غادي.
Hello everyone. Good afternoon. I am very happy to present this topic to you. It is the last lecture for today, so I hope it will be a lightful lecture for you. We learned a lot about hepatitis as a disease, risk factor, transmission, treatment, and so on. But we did not speak about most important thing in hepatitis as a disease, which is social and emotional aspect of the disease. Let's see how this affects patient life. We will see here the video to introduce you to the topic.
السلام عليكم ورحمة الله وبركاته. ممكن تعرفينا بنفسك وليش أنت معنا اليوم؟
وعليكم السلام ورحمة الله وبركاته. اسمي ملاك، عمري 30 سنة، مطلقة. حابة أشارككم رحلتي مع مرض التهاب الكبد الفيروسي بي حتى يستفيد الجميع.
متى عرفت أنك مصابة بالتهاب الكبد الوبائي؟
قبل 3 سنوات بعد التوظيف اكتشفت بالإصابة.
هل كان عندك أي معلومات عن المرض قبل معرفتك بالإصابة؟
نعم، سمعت عن هذا المرض بس لكن ما عندي المعلومات الكافية عن الفيروس.
هل تشكي من أي أعراض سواء قبل معرفتك أو بعد معرفتك بالإصابة؟
لا، بس أحس أحيانا بدوخات.
هل عندك أي أمراض مزمنة مثل الضغط أو السكر؟
نعم، السكري.
كلمينا عن شعورك لما عرفت أنك مصابة بالتهاب الكبد الفيروسي باء.
ما حبيت أني أتكلم مع أي أحد عشان ما حد يشفق علي، وحبيت أني أعيش التجربة لنفسي.
أنت الآن مصابة بالتهاب الكبد الفيروسي باء، هل عندك معلومات كافية عن طرق انتقال المرض؟
لا، لم يكن عندي أي معلومات الكافية. رحت لكذا دكتور، أعطاني معلومات عن الفيروس، وبعدها وقفت المتابعة عشان أنسى المرض.
هل إصابتك بالتهاب الكبد الفيروسي باء أثرت على حياتك اليومية؟
نعم، أثرت علي، وكنت بحاجة أني أرتب نفسي وأرجع للدكتور مرة ثانية وأراجع لمواعيدي ثاني مرة.
ما التغييرات اللي جريتيها على نمط حياتك حتى تساعدك في التأقلم على إصابتك بالفيروس؟
صرت أهتم بنفسي وبصحتي، وأنا الآن صرت أفضل ولله الحمد.
هل نصحتي أي شخص بإجراء فحص الفيروس الكبد باء؟
نعم، كلمت أهلي ونصحتهم، وكلمت الناس القريبة مني.
هل تعملي مع أشخاص مصابين بالتهاب الكبد الفيروسي باء في نفس مكان عملك؟
لا، ولكن أتمنى أن يكون في مجتمع للمرضى المصابين بالفيروس.
إذا عرفت أنه في شخص مصاب بالتهاب الكبد الفيروسي باء، هل حترفض التعامل معه أو حتتعاملي معه بشكل عادي؟
راح أتعامل معه بشكل عادي لأنه شخص غير خطير على المجتمع.
برأيك هل في أهمية للتوعية الصحية للمجتمع عن المرض وطرق انتقاله؟
نعم، مهم جدا عشان الناس تاخذ حذرها من هذا المرض.
أشكرك على حضورك معنا ومشاركتنا لقصتك وتوضيح أهمية وجود مجتمعات خاصة للمصابين بالفيروس، وبإذن الله مع التوعية المستمرة لأفراد المجتمع خصوصا العاملين في القطاع الصحي سيتم اكتشاف المزيد من الحالات وتقليل انتشار المرض والقضاء عليه بإذن الله.
So let's continue. We need to know if hepatitis B virus is still a burden. Of course, we saw before in the lectures, 292 million people are silently suffering from hepatitis virus, and 9 out of 10 are unaware of the infection. 2 out of 3 liver-related deaths are preventable and treatable. This is a study about hepatitis B virus disease burden in Saudi Arabia. Let's see here, the study took 10 years from 2007 to 2016. So we see here the incidence are not, the prevalence did not decrease dramatically, despite the cases are remaining stable. We see here from 2007 to 2016, the number of cases remain stable despite the declining in the prevalence. And although there is a decrease in the prevalence in the younger population because of the vaccination, but there is a lag of trend to be expected. Here is the distribution of cases in Saudi Arabia. Most of half of the cases in the western region, followed by southern region, and followed by central region. Here also the number of total Saudi population, and here the prevalence of hepatitis in the Saudi population. 262,851 cases are having hepatitis. 14% of the prevalence cases are diagnosed of hepatitis. And this number also, 37,440, is underestimated because not all of the cases know their hepatitis B virus status. So the number here is not sure because it's underestimated. And 14% of the diagnosed cases are treated. 14% of them are treated. And also this number is underestimated because not all of the cases of hepatitis B virus need treatment. So there is no established protocol for those who test positive and subsequent linkage to care are inadequate. In the absence of virological cure, a strong effort should be made to provide safe and effective lifelong treatment. So this is the patient journey, starting by the patient wondering if he have hepatitis B, then he decides to go to the hospital and understand the test, and after that diagnosed with hepatitis, and after the diagnosis what the patient needs from lab work and everything, then start treatment, and then long-term journey. And this long-term journey will continue whether the patient treated or whether the patient need only follow-up. Let's see a patient point of view. We saw the video aerial in this lecture. Let's summarize it in 3 points or 4 points. Let's see what the patient think when he have a chronic disease or when he have hepatitis. The fact it's a chronic illness, that means the patient will deal with the disease for a long time, and he should prepare himself for a continuous regular monitoring or medication for the rest of his life. The problem of hepatitis B virus, it's an infectious disease that maybe he have a stigma surrounding the diagnosis because it's an infectious disease. Having an infection that you cannot get rid of certainly make you feel cautious that you are harmful to others in a way you don't know. Maybe you can transmit the disease to other family member or friend in a way you don't know about it. And it's a progressive disease. So, it's a progressive disease. That means the treatment starts at a point when there is a liver damage. And when there is a liver damage, we can give the patient the treatment. So the patient, when he go to follow up, he is afraid and anxious that he reached the point of liver damage and need treatment. This is a survey about awareness and understanding of hepatitis B virus among sample of Saudi Arabia and United Arab Emirates. They asked them about hepatitis B virus. As we see here in the responses, most half of the sample said that they are aware of hepatitis B virus, but there is lack of knowledge in the transmission of the disease and the risk factor and consequences of the disease associated with the stigma surrounding the disease, and that prevent the patient from taking care and link to the treatment. This is another survey about, also for the patient, about how do you consider it to express your point of view or opinion at the instance during the journey as a patient. They ask the patient also to respond about this question, and they rank the answer from not all important to very important. So as we see here, almost 80% of the response said that it's very important to express their point of view when they are requirement to initiate new treatment, especially in chronic disease, and when there is an impact of treatment on one's life. And 7 out of 10 respondents say it's very important to initiate their point of view when there is a requirement to stop a treatment. And the lower portion of the sample said that there is very important to express their point of view when there is a lot of stigma surrounding the illness. Continue of the study, 41% of the sample said that they are not aware of hepatitis. 41% not aware of hepatitis B virus. And 24% they respond that they know how hepatitis B virus can be transmitted, and they know also that hepatitis B virus can lead to serious complication. And the lower percentage of the sample said that they know that aware of hepatitis B virus that can be prevented. This is another structured interview, also a small sample size from physician to the patient. They ask the patient, do you know any other member of your family or friend who suffer from hepatitis B virus? And most of the patients said yes, they know other family member have hepatitis B virus. And this is very important to have a clue that maybe hepatitis B virus run in some families. And they ask them, do you know how hepatitis B virus transmitted to you? And this is also very important because most of them said no. And how we can stop cycle of transmission if we don't know how the patient get the virus? We need to know which point the patient took the infection to stop cycle of transmission and to eliminate the disease. And also they ask about, are there any associations supporting hepatitis B virus patient in contact with you? And most of them, almost than 80% some of the sample said no. And as we saw in the video, we need to have society or a support group of hepatitis B virus patient because if we have a society group, we can eliminate the stigma surrounding the disease and we can treat the emotional and social aspect of the disease. Have you advised anyone to do screening? And most of them said no. And also this is very, very important because if the patient did not educate his family member and relative about the importance of screening, we cannot catch more cases. We cannot protect the relative or the contact from getting the infection. We need to educate the doctor, we need to educate the patient to bring his family member to do the screening and to discover if he have hepatitis or not. This is also a question. They ask them, if you discover the disease after premarital examination, will you agree to proceed? And most of them said yes, and this is a good point. Elimination of viral hepatitis by 2030 is one of the millennium goals of the WHO, but we cannot achieve it without collaboration of all stakeholders, include healthcare professional, patient, media, and policymaker. What are the challenges hepatitis B virus patients face? This is a study about common barriers that hepatitis B virus face, and it is a qualitative study. They conclude 3 important points. They said that people with hepatitis B virus, they need to have an information about the disease transmission. It's very important to have this information to prevent the disease spread to other people. And we need also to avoid the misconception about disease transmission, because most of people said the disease may be transmitted during sharing food or sharing casual contact, and this is very wrong. So we need to avoid the misconception about the disease, and we need to focus about emotional and social aspect of the disease. And the last conclusion of the study, they said there is a clear need for a patient community education to expand knowledge and awareness of hepatitis B virus. So we need to educate all the people in the community about the disease, and this is very important to increase awareness to achieve the elimination in 2030. So how we can start elimination? We need to have a starting point to start elimination of hepatitis B virus. So this meeting, hepatitis B virus call to action, were done before 2 years almost. They collect the most expert on hepatologists on infectious disease, and they ask them what is the most important starting point we can do, or what is the most priority we need to start hepatitis B virus elimination. They put these priorities, and the most important or the most ranked percentage or most 4 priorities rated by the physician, they said that it's very important to implement screening campaign. This is most 80% of the responses, followed by increase PCB education and awareness on hepatitis B virus, then improve linkage of care from PCB to specialist. This is the top 3 priorities to start hepatitis B virus elimination. They also put 10 key priorities to 10 key action to start elimination of hepatitis B virus. So number 1, assessment of burden of the disease and economic impact. We need to before start any elimination program, we need to see if we need this program or not. So we need to know the burden of the disease. It is the prevalence very high? We need to do it or not? Number 2, implementation of measurable, applicable referral way. We need to have a good referral system and clear protocol for the patient to reach the hospital. Number 3, inclusion of specific checkpoint. So we need to have checkpoint during the patient journey to make sure that the patient reach all the point and get the treatment or the follow-up. Number 4, we need to use KPI to see if this program is successful or not. Number 5, design and establish a tracking system in association with the MOH, and like we have in SANED program in hepatitis C, we need to have also electronic system for hepatitis B to track the patient and follow up of the patient. Also, they suggest that I think key action, we need to have age-targeted screening population. For example, targeted screening for the people aged 30 or more. Why? Because this is the most important group. This group, most of them did not get the vaccination. So we can start from this group. The people less than 30, most of them get the vaccination in the childhood. So we can start, for example, targeted screening for these people to see how prevalent hepatitis virus in this group. Number 7, to customization of screening campaign, the same with this point 6. Maybe this is targeted for specific age group, but number 7, we can do any screening campaign not specific to age group or people. Number 8, setting up target and incentive. We need to encourage the worker in the healthcare and in the lab to catch more cases and to detect the hepatitis B virus by screening. Then we can also create a free electronic module for healthcare worker. They need we need to encourage the healthcare worker by give them education and with accredited hour, so they can learn more about the disease and incentive for them. And the last point, increase awareness for patient diagnosed with hepatitis B virus. This is said in the beginning of the lecture. We need to increase the awareness of the patient from the doctor. If the doctor is not educated, the doctor cannot educate the patient, and the patient maybe transmit the disease to other people. So the starting point, we need to educate the doctor, so the doctor can counsel the patient, and the patient can advise his family. So, the summarized of this lecture, there is an unwillingness amongst people living with hepatitis B virus to disclose their disease status due to fear of stigma. Outside of specialist center, physician knowledge and expertise in this field is limited. You must seek out an expert to secure optimal treatment. Securing appropriate and prompt treatment remain a challenge. There is a lack of information and support for people living with hepatitis B virus. There is an appetite to receive tool or information to help understand the condition and ensure people feel better informed. In a patient journey, the instance where there is a requirement to initiate a new treatment, patients should express their point of view or opinion. Regard to the stigma associated with any illness or disease, as we saw in the survey, KSA resident rated less than UAA resident, 55 versus 75. Fourth of the respondents believe that hepatitis B virus can lead to serious health complications, while only 15% are aware of how hepatitis B virus can be transmitted. Thank you.
Thank you, Dr. Ghadi. Excellent review, and perhaps an element of hepatitis B management that not everyone is focusing on and giving it its due respect, and despite the importance of this topic. So again, we promised everyone to finish early, so maybe we'll limit the questions a little bit, but if we can get the Q code again in order to get the link for the questions. So if you allow me, I'll just have a few questions here. First one is about support group for hepatitis B. From what I understand, there's a need for those support groups. So what can we do to implement those, and any barriers to implement such hepatitis B support groups in the community?
Hello. Yes. I think we can start about education. When we found the cases, the doctor found the case, he can collect, for example, 10 people or 5 people, and say, starting from this point, okay, I have the group, society group, and the doctor maybe can be the leader of this group. And if we talk about the disease more, I think everybody will know about it, and everybody want to join these groups. So someone need to take step and do it. And I think if someone do it, everybody can do it. Nothing to prevent it. Yeah.
Okay, excellent, thank you. Another question, like now you have an excellent experience with hepatitis C and the management of hepatitis C in the community or in the primary health setting. Do you think there's a gap that we need to utilize the same tool for hepatitis B, or is it okay now to limit the treatment with an expert? So is it another way of putting it, is there an issue with access for experts now to manage hepatitis B?
I think there is a difference, of course, because in hepatitis B virus, we don't have a cure for the disease. So when we discover a case, we cannot do anything for the patient. This is very sad, because the patient only, he knows that I have hepatitis, and we can only bring his family to give them vaccination, and we cannot do anything for the patient. And most of the patient were lost because I don't have anything. I am very sad. I have this disease. For the rest of my life, I will visit the hospital. So I think we need to catch the patient and to make them feel that, okay, it's a chronic disease, but that doesn't mean you don't need to follow up, because maybe there is a progression of the disease in the liver and the fibrosis and so on. So we need to encourage the patient to continue follow-up. And we should do that by avoiding the stigma of the disease, because most of them, as I said, have fear about the disease. So this is my point, because we are thinking what we can do for the patient.
Excellent. So allow me again, the last question maybe from my side. There is a gap still between the prevalence of the disease and the number of diagnosed patients. So how do you think the best way of bridging that gap in the number of diagnoses of hepatitis B?
I think by screening, we need to do a lot of screening campaign. This is the most important way. If we don't do screening, we cannot discover the case, because it's a silent disease. Most of them doesn't have signs and symptoms. So I think by massive screening or targeted screening, we can reach a lot of the cases.
Okay. Let me see if I have a question. So it's online question. What is the current procedure to reach and educate and screen the contact of hepatitis B and C? Is it still involving activities within the PHC only, or it can be expanded beyond the PHCs? So where do we screen for hepatitis B and C now?
Now only we have screening like pre-marital, pre-employment, pre-surgical. We don't have any campaign for hepatitis B virus screening. Right now we don't have, and we need to work on it. So we can expand the procedure and discover the cases. But if we don't have the protocol for the patient after diagnosis, we cannot do anything. So we need to work on a protocol. When I discover the case, what I should do for them, the pathway. We need to complete the pathway to know if I discover the case, what I should do, and the end of the journey to the patient.
Yeah. So the linkage of care need to
need to be improved.
Excellent. I don't think we have any questions here. Just like to thank you on behalf of all the patients for hepatitis. I know the efforts that you're doing with the team in MOH. So we are really grateful on behalf of, again, all the physicians and all the patients. We thank you for your efforts, and this conference is one of those efforts. We'd all like to thank you.
It's my pleasure.
I think this is the end of the session. As we promised, alhamdulillah, we finished early. We'll see you inshallah tomorrow after Al-Jum'ah prayer. Thank you everyone. We'll see you tomorrow bidnillah.
في هذا الوقت أطلقت المملكة العربية السعودية برنامج طموح لإزالة فيروس الكبد سي، وذلك عن طريق 3 محاور رئيسية.
وحتكون أرقامنا قريبة جدا من الإزالة، وسنصل بإذن الله بتكاتف الجميع وجهود الجميع إلى الإزالة بإذن الله في عام 2030 كما كان مخطط له.
وضعت رؤية المملكة 2030 هدفاً طموحاً يسعى لرفع متوسط العمر السعوديين بإذن الله تعالى إلى 80 عام.